Thank you for your invitation to speak this morning. Myself and Kimberly, who'll be speaking after me, both work in Strive Clinic, which is a new, outpatient clinic based here in Galway as well as in Killybegs in South Donegal. And some of the issues that we'll speak about this morning are issues close to our own hearts, and certainly issues that we are dealing with on a daily basis in Strive Clinic. So first of all, thank you very much for your story, Mary. It was incredibly moving and quite difficult to come to speak after. So thank you very much for that. It was very moving. So I thought I'd start with what I consider a great quote that was actually written back 70 years ago by the World Health Organization, and it's a definition of health. So health is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And I think you're all witnesses to that here today. So I think this is what we aspire to, that it's not just the absence of disease, but it also is a state of complete physical, mental and social well-being. And certainly a lot of the issues that we deal with aren't just physical issues, they are psychosocial issues, and certainly what I'm about to talk about with you this morning will encapsulate some of that. So you'll all be familiar with the recent National Cancer Strategy here in Ireland. And what I think is great about this strategy is that the emphasis is, or a lot of the emphasis is on the survivorship aspect of cancer treatment, that it's not just about the acute treatment, it's not just about the detection, the diagnosis, but it's also on quality of life issues that are so important after cancer treatment. And really what I'm going to focus on this morning are two quality of life issues, namely, I suppose, urinary incontinence and also sexual dysfunction as well, because these are two issues that aren't talked about a lot. I suppose gynae cancer in particular really assaults the most intimate and private and vulnerable parts of our body. And so I think, issues like urinary incontinence and sexual dysfunction need to be brought into the open a little bit more and talked about. So I suppose over 120,000 people in Ireland at the moment are living with or beyond cancer. And of that number, between 65 and 90% of these people live with an impairment that is amenable to rehabilitation. Some of the quality of life issues, again, that we'd be familiar with in Strive Clinic, urinary incontinence, bowel control issues, sexual impairment, pelvic pain, fatigue, lymphedema, peripheral neuropathies, and of course mental health issues as well. And I'm sure some of you are familiar with a lot of those. So thinking firstly about urinary issues, what is the prevalence? So we think about 34%, certainly in one study, 34% of women treated for the three main types of cancer, of gynae cancers, had urinary incontinence. Now, another study, which was more of a questionnaire type study, would give the figure of 80, just under 84% of women after hysterectomy for gynae cancer had urinary incontinence, which is a huge percentage of women. I suppose of those women, just under 30% would have described their symptoms as bothersome. So I suppose the two main types of urinary incontinence that we'll come to in a moment, urinary urge incontinence seem to be to be very bothersome to 28.6%. Stress urinary incontinence was bothersome to 34%. So we'll come on to those definitions in a moment. And what's the prevalence of sexual issues after gynae cancer treatment? Again, astonishing figures. Nearly 90% of patients with a history of cancer have sexual dysfunction at some point in their cancer experience. 63% of ovarian cancer patients felt that their diagnosis negatively affected their sex life. Again, these issues are not just physical issues. There is an inseparable physical and psychosocial impact to these issues. So, urinary incontinence contributes to a considerable amount of anxiety for people. It contributes to fear and a sense of shame. And shame makes us want to hide away and to cover up. And certainly that is something that can happen with issues of urinary incontinence and sexual dysfunction as well. I think we experience a lack of freedom with urinary incontinence. We don't have the same degree of spontaneity. It affects our ability to go out for dinner. It affects our ability to get onto the bus and onto public transport. It affects our ability to hit a dance floor at a wedding. It affects our ability to go into town to shop because we have to look out for toilets all the time. So it has a significant effect on our quality of life on a day-to-day basis. We can alienate ourselves, we can exclude ourselves from social company as well. And, we may have this feeling of just feeling different to other people and pulling ourselves away from things. Urinary incontinence has been described in different ways in literature. So, one description of it is the silent epidemic. Many women don't feel they can voice their suffering, that they're the only ones suffering with urinary incontinence, that they can't say it. And I'd guarantee you, if you just bring it up in a group of close friends, that you will not be the only one there struggling with urinary incontinence. It's also called the Cinderella subject. Many physicians ignore the issue as being maybe unglamorous or not that important, a little bit inconsequential. And it's the last medical taboo. So I think healthcare professionals are not good at asking these questions. And I think that's actually established in medical literature that, that we can hesitate to really ask patients questions about their sexuality, about their urinary function, about their bowel function. And if you think back maybe over your own cancer journey, how often were you asked about your sexual function? How often were you asked about your bladder function along your own journey? So I'll not ask you to shout that out, but it's an interesting thought, isn't it? There's a clear association in literature between urinary incontinence and depression. These couple of studies that I've mentioned here aren't specific to gynae cancer survivors, but these are more sort of general population studies, but I think we can apply it. The first study of 82 women with incontinence, just under 20% of those women with stress urinary incontinence suffered a clinically significant depression. 44% of women with urge urinary incontinence suffered a major depression alongside their physical symptoms. Then a postal survey, I think this was one that was done in Australia, of 12,000 women aged over the year of over 40 years of age, and urinary urge incontinence was the greatest predictor of anxiety and depression with these women. 56% reported fairly frequent anxiety with it, and just under 38% suffered from a significant depression. So again, we can't just view this as a physical issue. So I suppose as a physiotherapist working with some of these issues, this is the key part of the body for me. I'm a pelvic physiotherapist, so a lot of what I do would revolve around the good old pelvic floor muscle, which I'm sure all of you have heard of at some stage in your lives. So I suppose the main function of the pelvic floor is a supportive role for your pelvic organs. It's very important for your bladder and bowel control, and it's got a key role in sexual function as well. So there it is inside the pelvis. It goes right from your pubic bone at the front, right underneath to the tailbone at the back, and then out to those seat bones that we're all sitting on at the moment, I suppose, at your tables. It's not a standalone muscle. It's linked to other muscles in the body as well, and we can't forget about these. So we have a unit, I suppose, of muscles called the cylinder of control, and that cylinder starts right up at your diaphragm. So your main breathing muscle, so pelvic floor work and breathing is very, very interlinked. Then we have the abdominal muscles and some of the deep spinal muscles, and then you have your pelvic floor underneath. So it's very much part of that unit of muscles. So when the pelvic floor starts to malfunction, these are some of the issues that can arise. They often don't just occur in isolation, they often occur as a group of symptoms. So, you may be noticing some urinary leaking, some people notice some bowel leakage as well, but that may be tied in with a little bit of constipation, or you might have a little bit of a feeling of something coming down or something prolapsing underneath. There can be a degree of vaginal or rectal pain, sexual dysfunction again, and pain in or around the pelvis. So these are all issues that can arise when the pelvic floor is a little bit weaker. So the main types of urinary incontinence, we've mentioned a few of them already. The top two really are the most common ones. You may have heard of these before. Stress urinary incontinence and urinary urge incontinence are the two main types. You can have a mixed component of both. Maybe one would be more predominant over the other. The bottom one is an overflow incontinence, which can occur for some people post-operatively, for example, where you may lose the sensation of having a full bladder. And then perhaps your bladder might be full, you don't feel that, you go from sitting up to standing and you have a large overflow of leakage from your bladder. So that can be an issue for some. Thankfully not that common, but it still is an issue. So what is stress urinary incontinence? Stress urinary incontinence is the complaint of involuntary leakage with a degree of effort. So this is where you might get a little bit of leakage when you cough or you sneeze or you laugh or you do a little bit of exercise, walking, dancing, that sort of thing. The leaking of urine tends to happen when you have an increase in pressure inside the tummy. So again, with a cough, you'll have that increase in pressure. That pressure goes downwards into the pelvis and can cause a leakage to happen. It tends to be a smaller amount of urine that will come away. Made worse by hormonal changes, made worse by constipation. If we have a few extra pounds on, that can make it worse as well. Any degree of lifting, particularly heavier lifting. So chronic coughing, smoking, and if you've had lots of babies in the past, then obviously that can be an issue as well. So urinary urge incontinence is where you get urinary leakage accompanied by or immediately preceded by the strong feeling of urgency. So when you've got to go, and nothing can stand in your way. So I suppose the main symptoms are that feeling of urgency, frequency, so going to the toilet very often during the day. So I suppose normal frequency would be somewhere between 6 and 8 times in a 24-hour period. So if you're going more than that, then you might have a little bit of frequency, and obviously that depends on what you're drinking as well. And nocturia, which is this feeling of needing to empty your bladder wakening you during the night. And having to get out of bed to empty. So those three would be the main symptoms of urinary urge incontinence. Not getting to the toilet in time is classic with this, and sometimes it's quite a large volume of urine that can come away. These are some of the things that can worsen urge incontinence, so anxiety. So you can see how it's a vicious cycle really. So it can make you feel anxious, and anxiety makes it worse, and so you're caught in this cycle. Lots of caffeine can certainly make it worse as well. Alcohol tends to feed into it. Hormonal factors again. Running water for some people can be a trigger, and some types of medication can make this worse as well. So I suppose after gynae cancer treatment, what changes happen to our pelvic floor? What changes happen to our vaginal tissues as a result, perhaps, of ovarian cancer treatment? So first of all, when you go through any sort of surgery within the pelvis, you have a risk to having some damage to the muscles and the nerves within the pelvis. And some of these muscles and nerves will be controlling your bladder. And your bowel function indeed as well. So just the nature of surgery is that it can weaken those structures. So obviously when your ovaries are removed, if you haven't already gone through the menopause, you're cast into this abrupt surgical menopause, which can be very intense, very abrupt form of menopause, and can you can have this rapid reduction in hormonal levels as well, and that in and of itself, that drastic reduction in estrogen can have a large effect on the pelvic floor, on the urethral sphincter muscles, which help to control the bladder, and on the vaginal tissues as well. And that whole vulvovaginal tissue quality can be compromised and reduced. The effects of chemo, are numerous. Obviously, the estrogen deprivation, the vaginal dryness, the thinning out of those vaginal tissues, the neurotoxicity, the neuropathy can affect the more sensitive parts of our anatomy, as well as the more peripheral parts like our hands and our feet. Obviously, the nausea, the vomiting, the diarrhea, the fatigue, the mucositis that goes alongside having chemotherapy is not good for our sexual function, for example, and not good for our bladders either. I'm aware that radiotherapy isn't one of the primary forms of treatment for ovarian cancer, but if you have been through any degree of radiotherapy, then certainly that will have a significant effect on your vaginal tissues, on your bladder tissues as well. You can have a lot of bladder lining irritation causing urgency and frequency again. There's changes to the elasticity of any tissue really that is exposed to radiotherapy. Scar tissue formation, adhesions, what we call fibrosis, and ultimately a narrowing of the vaginal canal as a result of radiotherapy. So, all of these changes again to a very sensitive, very intimate part of our bodies, and can certainly have a significant, profound effect on our quality of life, again, day to day. So I suppose as a physiotherapist, again, this would be my approach to treating anyone with these issues that we're mentioning. So really when we're looking at pelvic floor rehab, I'm sure the first thing that jumps to your mind is pelvic floor strengthening and getting those exercises out from the back of your minds that you were maybe taught years ago. And that certainly is part of it, but it's not all of it. And hopefully what I'd like to instill, I suppose, today is just an awareness of different types of issues that can arise within the pelvic floor itself. So, obviously we can have just weakness in our pelvic floor, and what we need to do is we need to get those exercises out and to strengthen it again. We can also have what we call a poorly coordinated pelvic floor. So what do we mean by that? Well, a pelvic floor that doesn't work effectively alongside the rest of that cylinder. So for example, you might try to do your pelvic floor exercises, but you just can't get your breathing going. You can't coordinate the breathing element into that. And that's a very common issue with a lot of women doing their pelvic floor exercises. So, there's some issue around coordinating the pelvic floor muscle with other muscle groups. And then there's this extremely important area of pelvic floor work, which is the overactive and the tense or painful pelvic floor. And certainly with gynae cancer treatment, again, it focuses in that very core part of our bodies, and even just the nature of going through that treatment might mean that we tense up our pelvic floors without even realizing that we're doing it, and they can become quite tight and quite tense over a period of time. And if that's the case, if you were to go in and then do pelvic floor exercises to strengthen your pelvic floor, you might actually make things worse. So it's very important to try and discern, is someone's pelvic floor just weak? Or is it just not coordinating very well with those other muscles? Or is it a case of it being just tight and painful and a little bit tense? And the focus for physiotherapy then would be different with each of those, in each of those categories. So with the weak, the poorly coordinated pelvic floor, again, what we need to do is we need to locate that muscle, we need to strengthen it over a period of time, and once we've strengthened it, we need to keep it strong. Those are the challenges for a weak and poorly coordinated pelvic floor. Whereas with an overactive or tense pelvic floor, what we're thinking of more is how can we relax it, first of all, how can we let it go so that it can go back down into the pelvis. We might need to do some stretching work or some massage type work on your pelvic floor, which is part of what we do in physiotherapy. We want to release that pelvic floor before we can strengthen it. So, first of all, if your pelvic floor is weak, and what we need to do is strengthen it. These are some tips for doing that. So first of all, our posture is very important. And this is usually when everybody sits up really, really straight in their chairs in the audience. But so we do want to be in a good posture. I suppose if we're slumped back into our sofa, that's not the ideal position for doing pelvic floor work. We want to be in a fairly upright position where our weight is going down through those seat bones, and not that we're rigidly upright, but that we're in a nice, comfortable, relaxed, fairly upright position. We want to be breathing as well, needless to say. We want to keep our breathing going as we do our pelvic floor exercises. And then we want to have a correct tensioning of the muscle and an ability to let it go. So those are the really important aspects. So, even if you want to try this with me as you sit in your chair, if you get into a nice sort of upright, comfortable position, these are some of the verbal cues that we would use for pelvic floor work. So I suppose you're focusing in on the passages underneath. You're focusing initially on your back passage, because that's where the bulk of the pelvic floor muscle is, actually. So you want to squeeze from your back passage as if you're closing, and then bring that squeeze forwards and upwards to your middle and front passage. Okay, so it's coming from the back, you're lifting it upwards and forwards. So you should feel a little bit of a squeeze in from below as you do that. Check your breathing just now. So are you still breathing, first of all? If you're not and you're holding your breath, just let it go again. So let's try that again. This time take a little breath in first, and as you breathe outwards, see if you can pull in a little bit with that pelvic floor. So squeezing again from the back passage, bringing it upwards and forwards towards the front as well. Hold it there. Oops, Doozy. Hold it there for a few seconds if you can. If you ideally can hold it for about the 10 seconds, that's great. And keep breathing as you do that, even if you can just take little breaths in. And then just let it go again, and see if you can feel a bit of a drop down as you let that muscle go. See if you can feel it drop back down again into the pelvis. Okay, so that's your basic pelvic floor contraction. We encourage, for strength training, we encourage you to do slow ones, and we encourage you to do fast ones. So your slow ones, you're squeezing in from the back, you're lifting it upwards and forwards, you're holding it there for the 10 seconds, if you can. And then you're letting it go again. With the little fast ones, what you're doing is you're squeezing and you're relaxing. You're squeezing and you're relaxing. So you can see the difference there between the two different techniques. So both are important. Aiming for about 10 of each. Aiming for 2 or 3 times a day if you can with your pelvic floors. And for the gentlemen in the audience, you have one too. You have a pelvic floor muscle. And pelvic floor muscles are equally as important for men. Particularly as they progress a little bit more in life. So it's certainly one for you guys as well. We have little functional exercises as well. So say, for example, if you were to experience a little bit of urinary leaking as you were coughing or sneezing, then to try and get that muscle to kick in for you just before the cough or just before your sneeze can help to stop that leakage from happening. So that is a challenge. So really for pelvic floor training, a supervised strength training protocol is what's recommended, with close to maximum contractions for at least 8 weeks. So this is something that we need to keep doing. It's not going to be an overnight fix. It's something we need to persevere with, and really, in the process of physiotherapy, we're often looking at 3 to 6 months to really see a difference to someone's symptoms with strength training. What are some of the common errors? We've mentioned some of them already. So over-contracting those abdominal muscles, so really tightening around the tummy can be an issue for some people. Squeezing the legs together, we're just trying to get anything going underneath there, and often too much can happen. Lifting up off your chair. I didn't see any of you doing that actually a few moments ago. So lifting off your chair can be an issue. Even lifting those eyebrows, we're trying to concentrate so hard on getting that internal lift and squeeze that other things can lift as well. Stopping breathing or holding our breath, straining down. And I suppose the key message is that no one else really should be able to see you doing them if you're doing them correctly. So if someone notices a few other things kicking in, then possibly there's a little issue with your technique. This is the question I get asked most. How do I know if I'm doing these things properly? And I suppose there is a little bit of bad news with the research, with verbal instruction. So I've just been giving you verbal instruction in how to do your pelvic floor exercises. With that alone, less than half of all women are correctly doing them, which is quite a high figure again. A significant number of people will actually be pushing down instead of lifting up with their pelvic floor. So a lot of the NICE guidelines that we would base our practice on would recommend a routine digital assessment. You do not know if you're doing them correctly unless someone checks it for you. And that's what we do on a daily basis with pelvic physiotherapy. We check to see, because otherwise we don't know. Do you have a weak pelvic floor, or is there a little bit of overactivity there? Is it a bit tense? So really the only way of knowing that is to be checked. So with pelvic floor muscle training, it's the first line of therapy for stress urinary incontinence or mixed urinary incontinence. So any guidelines that you read will say, try this first, give it your best shot. Hopefully that will work for you, and the success rates are fairly high with this before you consider any other sort of management strategy. Pelvic floor training is safe, it's got no side effects. It's not expensive to do. They're simple to perform. Pelvic floor exercises, you don't need any instruments to do them. They can be done anytime, anywhere. So, they are fairly, once you've got the technique right, they're fairly easy to do. The effectiveness of pelvic floor training for urinary incontinence among gynae cancer survivors. This study in 2014 looked at women who'd been through gynae cancer treatment. 95% of them had surgery, 35% had chemo, 18% had radiotherapy. And of this group, the treatment group had pelvic floor muscle training and something else that we call behavioural therapy, and I'll explain a little bit about that in a moment. And after 3 months, 80% of those women reported being much better or very much better. So that's a high percentage that just feel better having done some basic exercises and making a few little changes in their daily lifestyles. So, high adherence to this is definitely important as well. So really sticking with them. What are some of these behavioural techniques that we use? I suppose it can be anything from looking at what you're eating and drinking in the day. So, the basics, how much caffeine are we having, for example. There are other, what we call bladder irritants as well, and we'll mention some of those in a moment. Things like, a lot of citrus juices can be an irritant to your bladder, for example, or carbonated drinks, fizzy drinks can be another bladder irritant as well. So really, looking at fluid intake, we want to aim for about 2 litres of fluid on average in the day, unless there's a specific reason for needing more than that. And with 2 litres of fluid intake, we're aiming for 3 to 4 hourly, approximately, toilet visits in the day. Okay, that would be the kind of the baseline. So if you find that you're going a lot more than that and you're running to the toilet every hour or two in the day, you might want to consider some bladder retraining, where I suppose the goal of bladder retraining is to increase the capacity of your bladder to hold a little bit more and to restore normal bladder function. And the aim is to reduce your frequency so that you don't have to go quite so often. And there are some little urge suppression techniques, as we call them, that can help with that as well. We want to try and avoid constipation and reduce lifting and all of these things that we can manage ourselves on a day-to-day basis. And we obviously want to watch our weight as well, which is a factor with urinary incontinence. So fluid changes again, trying to reduce or eliminate caffeine completely. Decaf drinks, there are lots of them out there that can be good alternatives. Trying to avoid alcohol. Maybe, if getting up in the middle of the night is an issue, trying to pull back on your fluids before bedtime. So, it takes a drink, for example, a glass of water will take about an hour to an hour and a half to filter through our systems into our bladder. So, you need a little bit of time between your last drink before bedtime for that last drink to empty. So if you can, leave that for, we would recommend 2 hours before bedtime for your last drink. And just avoiding those carbonated drinks and those citrus juices as well. So I just want to say a little bit, I'm nearly there, I suppose, on the whole area of the tense or overactive pelvic floor and what we do with that in physiotherapy. So I suppose a tense or overactive muscle is a short muscle. It's not a nice long muscle, but it's in a shortened state. It's also a weak muscle, and it's unable to let go and to relax fully. If you have a shortened muscle anywhere in your body, that can cause tension, it can cause pain, and that's the same around the pelvis as well. So if you have a shortened pelvic floor, that can cause pain as well. If you have a shorter pelvic floor or a tense pelvic floor, you probably will have pain with sexual intercourse. So this is a key area really in the whole sexual function area. You can also have issues emptying your bowels. Defecation dysfunction is a medical way of saying that you can have problems actually emptying with the actual emptying of your bowels, and urinary issues as well. So the tense pelvic floor is a key area. So why have I stuck the image of an elbow up on the screen? I suppose I just want to relate it to a different part of your body. If you were wanting to strengthen this muscle in your arm, to effectively strengthen your biceps muscle, you need to be able to bend your elbow right up through its range. It needs to go right from here to here. If that muscle was short, you might be able to take it just from here, for example, to here. So you're just strengthening a shortened muscle through a small range of movement. Whereas what we need to do first is we need to lengthen that muscle out so that then we can effectively strengthen it. So that's why I wanted to relate it to a different part of the body. So what is the treatment for a more tense pelvic floor? Well, we have a number of relaxation type exercises. Some of those are nice visualization type exercises that you can do to help to release and to relax the pelvic floor. We use a lot of abdominal breathing. Because if there are issues with, I suppose, your breathing technique, some people will breathe a lot from up here when they have a more tense pelvic floor, and we need to try to get your breathing down and into your tummy and into the diaphragm as much as possible. So we'll do a lot of work on that, and even just by working on that, sometimes the pelvic floor can release that little bit more. We also do some manual therapy work. So we, as physios, we do a little bit of internal work where, like a muscle anywhere in your body that is tight and overactive, we do a few little trigger point release techniques, we call them. We will try to mobilize some scar tissue and do some different types of massage work to help that muscle to let go and to release. So with sexual issues then, as well as doing some of those techniques, so the pelvic floor rehab and the manual therapy, you know, there are moisturisers, there are lubricants out there, and we'll come on to the difference between those two in a moment. Talking to your gynecologist about sort of localised estrogen creams, they'll guide you there if those are appropriate for you. There's something else that we call Dilator Therapy. We'll come on to that in a moment. And obviously, again, the physical and the psychological can't be separated, and psychosocial counselling can be a very important part of what we do for these issues. So what is the difference between a moisturiser and a lubricant? Moisturiser is something that you can use to hydrate your vaginal tissues. So it's something that you apply often 3 to 5 times a week. It just helps the quality of those vaginal tissues. And obviously if you're moisturising and you're taking away some of that dryness, it can help with vaginal comfort just for intercourse. So that can come in gel form, in tablet form. Some of them are over the counter, some of them actually you can get on good websites online. And lubricants are slightly different then to moisturisers. So lubricants are something that you use immediately prior to sexual intercourse, or prior to gynae exams, which can be very uncomfortable for people, or whatever form of vaginal insertion. So, you know, it's used just before that activity. So it can be used prior to, during sex. Again, it comes in liquid or gel forms. Water-based and silicone tend to be best. And you apply in the vagina, around the genitals, and also on your partner as well before intercourse. So, there is a difference there between what you're trying to achieve with a moisturiser and what you're trying trying to achieve with a lubricant. And some of you may be familiar with Dilator Therapy. Some of the doctors will recommend this as well. And basically the purpose of dilators are just to increase the elasticity around your vaginal tissues. And you know, if you're experiencing any discomfort with gynae exams or with intercourse, then sometimes dilator therapy can have a positive role there as well. So really, what is the key message of what I've been trying to get across this morning? I suppose accepting a reduced quality of life after surviving gynae cancer is not obligatory. There is lots that can be done for some of these more sensitive issues surrounding gynae cancer treatment, and pelvic physiotherapy is one way to help to ease some of the discomforts that you may be experiencing. Just to say a tiny little bit about Strive Clinic. It's a new outpatient clinic here in Galway and up in Killybegs in Donegal. It's very much an interdisciplinary model of care, so you will find a lot of different, I suppose, allied health professionals there. There's myself. As a pelvic physiotherapist, there's also a physiotherapist dealing with lymphedema there. Kim, who is about to talk to us, is an occupational therapist. They're from a mental health point of view, there'll be a psychosocial counsellor coming on board in January and a psychologist. We have a psychotherapist there at the moment. We have a speech and language therapist. We'll have nurse specialists. We have a dietitian as well. So, you know, we're very much an allied health team. And the large part of the focus at Strive is cancer rehabilitation and survivorship. So just to let you know that we are there, that there's a stall at the back as well. You can talk to Tom or Kim or myself. We'll be here around for a while. So again, thank you very much for the opportunity to talk today. And I'd like to answer any questions you have perhaps after Kim's talk. Yeah, lovely. Thank you.